Provisor's numeric scoring system for periodontal disease is a more precise way to measure disease and severity than text linguistic descriptions. This is partly due to the fact that numbers are less ambiguous than words, partly because progression or improvement in the disease state can be quantified more precisely with a numeric system, and partly because there is no universally agreed upon gold standard for describing a periodontal disease state in words. Page and Ecke explained the problem in their July 2007 Journal of Periodontology paper by stating, quote, "Many definitions of periodontitis have been used in the literature for population-based studies, but there is no accepted standard." What this means in practical terms is that two clinicians could describe a disease state of a patient differently, where in an extreme example, one clinician's targeted state of improvement following treatment could be another clinician's starting point indicating treatment. Provisor's numeric scoring system eliminates this problem and establishes an objective and reproducible scale that can be used on all patients by all clinicians. However, since this numeric system, though intuitive, is unique, how does one calibrate the expectations of a patient who is going into treatment for periodontitis? For example, is it reasonable that a patient presenting with a disease score of 65 could achieve an endpoint score following treatment of 4? A paper in preparation by Provisor that looks at treatment data from 900 patients in the care of 9 different periodontists examines this question and provides guidance on what a reasonable target score following treatment should be for patients presenting at different levels of disease severity and extent. In the study, patients were retrospectively Provisor assessed for risk and severity from baseline records at the point they entered the care of the periodontist. Scores were calculated from the records through a mean study period of just over 13 years, with the active phase of treatment extending over a maximum of 2 to 3 years, followed by extended maintenance to ensure stability. When published, the full paper will be posted to Provisor University, but for now, let's take a look at the important conclusions we can draw from this study. From this data, we can see that patients presenting with higher disease scores can be stabilized at a lower score, but on average, the score at which stability is reached will be higher for patients presenting with higher initial disease states. Dentists can use this information to appropriately set the expectations a patient might reasonably have following treatment. For example, a patient presenting with a disease score of 40 might be told, quote, "Mrs. Jones, your Provisor score is 40, representing localized mild and severe periodontitis, and requires treatment to ensure optimum oral and overall health. The good news is that with appropriate therapy, most patients will respond positively, and we should be able to get that score under 30. Our goal is to stabilize your score after controlling the infection causing the disease, and at that point, we should be able to maintain you in that stable state for years." For a copy of this presentation, just visit the Download section of Provisor University.